So, welcome everyone. Good afternoon. Thank you very much for attending today's sessions on our product launch DynaMesh in Singapore. Yeah, it's our pleasure that after a year and a half of registrations, we are now fully available with our full portfolio in Singapore, and to introduce ourselves, our company, our philosophy, and our products to you. And it's a great pleasure that we are not only able to do that from our company perspective, but also from, even more importantly, a fellow physician's perspective for you. So it's a great pleasure that we not only have Dr. Philipp Schuster, our Director of Clinical Affairs with us to introduce the company and our philosophy a bit, but also to have Dr. Thomas Simon and Dr. Clinton Luedtke, sorry, two experts and experienced users of DynaMesh products. Dr. Thomas Simon is the head of visceral surgery department in the Spital Wallis in Visp in Switzerland. He was educated in Germany, but moved to Switzerland in 2018, I believe, and has been there the head of the visceral surgery department ever since. He is going to introduce a bit the IPOM technique and some specialties of our DynaMesh IPOM in combination with that. Our second physician speaker is Dr. Clinton Luedtke. He is the head of the Hernia Center at the Westphalsklinikum in Kusel, Germany, and he was at the most recent EHS Congress in Copenhagen named a fellow of the European Board of Surgery and Abdominal Wall Surgery, one of the first in Europe. Yeah, so without much further ado from my side, just a few house rules, maybe let's call them. If there's any questions during the presentations, please use your raise hand tool or use the chat. If you raise your hand, I will activate your mic so you can just ask your questions. If you write them in the chat, I will go through them at the end of each presentation. Yeah, so I think we start just as we have outlined in the program with Dr. Philipp Schuster, who will give a short introduction to the company before we then switch to Dr. Simon and Dr. Clinton. Dr. Schuster, do you want to just...
Yes. Thank you, Konstantin. Also, warm welcome from my side. I will start sharing my presentation. Here we go. Should work, does it?
Yes.
Perfect. Okay, so you're all waiting for the more important part, the perspective of the clinicians, I know, so I will keep my presentation very short. But allow me to give at least a few slides about the history of the company, and second issue, the unique selling propositions of our products. So let's go back to the very beginning, just two slides of this, because I think this is very important to understand also the philosophy of our products. FEG is the manufacturer of the products with the brand name DynaMesh, and FEG is an abbreviation, complicated German term, Forschungs- und Entwicklungsgesellschaft, which is nothing else than a research and development corporation. So FEG started as engineering service provider for the textile machinery industry. So we were involved in projects developing knitting machines, weaving machines, other machine types for the textile machinery industry. And then more by a coincidence, we became a project partner of a project which was funded by today's competitor, Ethicon. And Ethicon approached the University Hospital in Aachen with the development of a new mesh, which finally is known as the Vipro mesh. So an FEG became project partner because there were in the project they identified a lack of textile engineering competence and processing competence. So that is where we jumped in, and we needed to learn actually in this project that not all of our ideas could be realized because of many restrictions given by the funding company Ethicon. Today, and years later, we understand much better where these restrictions came from. If you once have approved a material, for example, for medical devices, your interest in changing the material is not very high, because it's a huge effort to approve a new material. So polypropylene was the approved material on Ethicon side, so there was a restriction, please stick to this material. And same story also for textile structures. There was an existing and approved machinery park, so we could not really think out of the box if it comes to the details of the textile structure, because we were limited to the machineries available and approved already. So that was the point where we decided, or the CEOs decided, to realize those ideas in our own products. In 2004, then we launched our first implant, the IPOM implant, and there the story begins actually. In 2014, we moved to this building I'm sitting in now, and just 2 years ago, we added another 600 square meters production and storage capacity. This gives a brief overview of the available products for the business field hernia. So we are actually active in 2 business fields. One is hernia and the other is urogynecology devices. As I said, 2004, we launched our first product, which was the IPOM, so the mesh for ventral hernia repair in an intraperitoneal position. Added in 2007 by another device for also intraperitoneal placement, but a device for parastomal hernia treatment as well as prevention. In 2010, we added another product, the DynaMesh C-Cut, also for ventral hernia repair, but in the extraperitoneal position. And in 2011, we completed the product range with devices for inguinal hernia treatment. So the DynaMesh Liechtenstein is a device for open inguinal hernia treatment, and Endolab for the endoscopic, laparoscopic techniques, DEP and TAPP. This was added by another version of hernia mesh for inguinal treatment, the Endolab 3D, which is a 3-dimensional pre-shaped mesh. And the last indication we couldn't serve with the product is the hiatal hernia. And there we added another product in 2016, the DynaMesh hiatus. 2019, these are devices which is a variant of the 2007 initially launched IPST. So this is the entire product range for the hernia treatment. This is the same chart giving an overview about the products for urogynecology. I will not go into detail here. Just the 2 major indications here are incontinence and prolapse treatment. Okay, and that brings us to the unique selling propositions of these products. And I picked the 2 major unique selling propositions. First, the material, and second, the textile engineering performance, which is realized in these products. So let's start with the polymer. We are the only manufacturer producing these meshes out of Pvdf, polyvalent vinylidene fluoride. Competitors usually use polypropylene, polyester. These are the major other polymers. Why do we use Pvdf instead of these other commodity polymers? 3 major reasons. First, Pvdf has an excellent long-term stability. Second, a very low foreign body reaction. And third, it's a polymer which can be used without additives. So a very high purity of this polymer. a bit more into detail. So there's a bunch of literature demonstrating that Pvdf has a superior long-term stability compared to especially PP, which was also confirmed by a statement in the latest international guidelines for groin hernia management, where it says under electron microscopy, human mesh explants, no matter made of which material, all show signs of degradation, but Pvdf has the highest resistance to degradation. And of course, it's helpful if a meta-analysis by a guideline team comes to this conclusion in an official guideline document. Second, the low foreign body reaction. So we all know, no matter which foreign material, they all evoke a foreign body reaction in once they are exposed to physiologic conditions. But what can be measured is the thickness of the foreign body reaction. Separated in an inner and outer granuloma, you measure a 300 microns foreign body reaction on the surface of Pvdf, while the thickness of the foreign body reaction on PP surface is measured to be 500 microns. So this is a significant lower foreign body reaction. And this is important when it comes to the incorporation of the mesh. When we start with the textile pore on the very left side, and we add now the inner and outer granuloma, then the goal is always to design a mesh, a pore size, which is large enough to guarantee that after the foreign body reaction, so on the very right side, there remaining a certain porosity. So if you start with too small pores here, or you have too high foreign body reaction, these pores will completely be closed by scar tissue, which will end up in a scar plate. This was known in the past. Today, we usually talk about meshes with clinicians like to call them the lightweight meshes, but it's not the weight, it's rather the pore size which is important. So large pore meshes, this is a standard, and that is what is considered in all of our products. Last thing, the purity. So to understand that, you need to know a bit more about polymers. Not all polymers do have smooth native properties which enable them to be processed smoothly. So there are additives which are necessary to process the material in certain production techniques. This is the one issue why, or the one reason why additives are added to polymers. Second are the use properties. So to make polypropylene more long-term stable, there need to be additives as antioxidants to be added to polypropylene. And Pvdf indeed is one of very few polymers which have really good native properties. So you do not need any additional additives to process this polymer adequately, and neither to adapt or to improve the use properties of this polymer by adding other substances. And also this was stated in the same guideline document, the International Guidelines for Groin Hernia Management, where it says notably only few polymers, and one is named Pvdf, can be used without additives. And we believe this is a third very important point when it comes to the superiority of Pvdf compared to other polymers available. And then we switch to the second unique selling proposition, the textile engineer. If you see in the difference, the variety of the morphology of these structures in the background, you will immediately understand that all these structures have completely different mechanical properties when it comes to stability and elasticity, and that is actually the goal of the research and development department, to adapt the properties of the mesh to the individual requirements of the indication. And a very important aspect here is that you have the full production line under control. As more processes along the production line you have under control, as more parameters you have available to adapt the properties of the device. And we do have the fully integrated production line in-house. So we only buy the granule and then we start spinning our own fibers, and we do the preparation for warp knitting, and we do the warp knitting in our own machines. Just sterilization is finally done outsourced. So this is an important point to know. And then it comes to the point playing with these parameters all along the process chain to adapt the properties and find the best trade-off decision for an ideal stability, elasticity, and porosity. These are the major parameters of a mesh. Finally, also an issue of textile engineering, I would like to present to you on just one slide an additional feature which we offer for all of our products, which is the visible technology. So conventional mesh implants are not visible in commonly used imaging technologies as CT or X-ray or MRI. So the idea was to create or to develop a mesh which is visible under these commonly used techniques. And this initially was intended to be used as an helping tool, as an additional tool for the research and development department to learn how meshes deform in the body after they're implanted, after desufflation, for example. And they asked themselves, if we know how the mesh looks like after desufflation, it's easier to create a pre-shape to the mesh. That was the starting point. And then clinicians became interested in this technology to answer crucial research questions as mesh shrinkage, for example. This is an ideal technique to observe the behavior of a mesh in vivo. And that was the point where we decided to also add a visible version for each of our products and offer them to the market. And today there are also a bunch of publications available demonstrating the benefits of visible mesh. This is just one example here, which is an IPOM mesh. I think this is a study by Moisems in Ghent. So this is the major aspects on the unique selling proposition. So material and textile engineering, that should be enough from my side. And it's my pleasure now to hand over to the more important, the clinician part of Dr. Luedtke and Dr. Simon. Thank you very much.
Perfect. Thank you very much, Dr. Schuster. Yes, correctly. We are now going to continue with Dr. Simon, who is going to introduce his presentation. Is the IPOM procedure the better choice in incisional and ventral hernia repair? Very much looking forward to that. Dr. Simon, the stage is yours.
Yeah, good afternoon, ladies and gentlemen. My topic I will discuss is the treatment of incisional and ventral hernia repair. And I can state that I work with the products of DynaMesh now for at least 15 years now. And I hope you can see my presentation. And I will start with a discussion or the issue about incisional hernia. The incidence is very high, as you know. There are several studies showing that the incisional hernia for all patients going through a midline incision is at least 13%. And if you look for subgroups like colorectal carcinoma, it can be up to 40%. And even more for abdominal aortic aneurysm, almost 70% are suffering of incisional hernia after the midline incision. So we have to deal as clinicians for the most frequent complication after the midline incision. And for our patients means that they have an increased morbidity and mortality. They have a decreased quality of life, and we are producing a lot of cost after these operations. So what shall we do? Shall we treat every patient with the incisional hernia? You know, there is this PROLOV trial from the Swedish colleagues, which showed in 2016 that analyzing their hernia registry, they could show that at least all the patients are have a benefit of treatment for their incisional hernias regarding quality of life. So we know we have to treat them, but the question is, how can we do that? Is it the open extraperitoneal repair, for example, the sublay repair, which has the advantage of an abdominal wall reconstruction, less expensive meshes, and an open access to the abdomen, but the disadvantage of a quite severe tissue trauma and wound complications? Or is it on the other side the laparoscopic approach, the laparoscopic IPOM as an intraperitoneal mesh placement, which has the advantage to be minimal invasive with less wound complications, shorter hospital stay. But on the other hand, we need expensive meshes and we have the risk for unrecognized bowel complications. In my own data, you see here, it's quite old, 10, 12 years old. You see that we in 2010 started earlier with the use of laparoscopic IPOM, but it was always increasing. And also in the years after this period, we had about 60% of our ventral and incisional hernia repairs done by the IPOM. And if you look for the German hernia register data, you see that the laparoscopic IPOM is the red line and the open sublay repair is the blue line. They are the most frequent techniques for repairing incisional hernias. But there is a quiet development due to the new techniques in open repair, where the surgeons try to avoid bigger incisions. So the question arising is, what shall we do? Shall we choose the laparoscopic IPOM or the sublay, open sublay repair, the extraperitoneal mesh placement? What we will achieve is a recurrence-free survival for our patients, which is pain-free and will have a high quality of life. So we should look for the evidence which will help us to answer these questions. An expert recommendation, as shown here, is only that we know the ventral hernias, they need a mesh when they are bigger than 2 centimeters, but no recommendation for open sublay or lap IPOM. And then we have the problem looking at the evidence. If you look for all these older publications, they were mixing incisional hernias and ventral hernias. And that is a problem due to completely different entities. They have significant differences regarding surgical technique and outcome, as you see here, published by Ferdinand Köckerling in 2015, looking for the data in the German database registry. And they could show that they have really complete different outcomes in terms of recurrence rates, pain, and also postoperative complication. And also in this study, it could be shown that primary ventral hernias and incisional hernias are different entities. So if we only look for incisional hernias, the older data, RCTs, randomized controlled trials, they are not very much patient included, and they couldn't show any difference between both operation techniques. And then we have this meta-analysis from 2015 with six randomized controlled studies, which show 2 important points. The first one is that with the laparoscopic repair, we have a significant reduction of wound complications, but on the other hand, we have this higher rate of bowel complications. I think this is every surgeon who is dealing with these kind of operations has this experience. And now finally the guidelines written published 2015 in Europe and also in the United States, the SAGE guidelines stated that the laparoscopic approach is superior to the open approach as a result of a significant reduction of wound complications, but it has a higher risk for intraoperative complications. And then we have the update from 2 years ago for the European Hernias, the International Hernia Society. And they added 2 statements or 3 statements. One is important, that the learning curve for the laparoscopic repair is quite long, but the laparoscopic approach has a significant lower risk for wound infection, also in the group for incarcerated and strangulated hernias, but the missed bowel injuries are more common in this group. And then finally, we have the data from the Danish hernia registry. They also came to the same conclusion and showed that the open mesh repair has a higher incidence of mesh-related complications. As you can see on this chart, the blue line is the laparoscopic surgery group and the yellow line the open surgery group. And also regarding hernia recurrence, they could show that the open mesh repair is, has a higher risk for hernia recurrence than the laparoscopic repair, as you see here also in this chart. So now I showed you quite a lot of data, and the question is whether evidence is achieved and we can make a good decision, or do we need furthermore RCTs to have better data? RCTs are always a problem for these kind of questions because they are very difficult to perform, they are quite expensive, and then they have the problem that they can't be validated externally. So what have we else? What kind of tools do we have else? So we have, for example, our registries, like prospective observational studies, but they have always the problem that you never know how to deal with the differences in the groups. They are not explained by the treatment. So, and then you have these confounding biases. So one new tool is the propensity score matching. And I just want shortly to explain how this works. With the propensity score matching, you always choose 2 pairs which are the similar characteristics, which are potentially influenced by the treatment. And then you have the possibility that you compare those similar patients with each other. And the only problem is that you have unknown confounders which you can't account for. So we did this examination with the Hernia Hernia Registry in Germany 4 years ago and published it in 2018. And we analyzed 10,000 patients, and we had the objective to compare laparoscopic intraperitoneal onlay mesh versus the open sublay technique for the elective incisional hernia repair. And the outcome variables were complications, pain, and recurrence 1 year after the treatment. And the matching variables to have similar groups were age, sex, BMI, ASA score, preoperative pain, defect size, defect location, and the presence of at least one of the risk factors. These are the groups. And with the matched groups, we had nearly 4,000 patients with the matching percent of 96%. Here you see the data at the same age, same BMI, but you see a little bit difference between the treatments. The lap-IPOM group has a little bit more combined locations, whereas the sublay group has more medial locations. And then we have smaller defect sizes in the lap-IPOM group and quite more risk factors for the sublay group. The results are here. You see the meshes, the lap-IPOM meshes were used in this analysis. And you see the both blockbusters here, DynaMesh IPOM and the Paritex mesh. To show you the results of this analysis, you see that regarding recurrence and the pain, we have no differences between lap-IPOM and sublay. But the disadvantage of the open sublay, you see here postoperative complications significantly more often in the sublay group, complication-related reoperations more often in the sublay group, and also the general postoperative complications are quite more often in the sublay group. On the other side, we have the lap-IPOM with more often complications, intraoperative complications like bleedings and bowel injuries. And then if you look for the results in the hernia registry with at least 100,000 incisional hernia repairs published last year, you see that the quality of the treatment was getting better and better over the years. But still you have the blue line, the lab IPOM line, and then you have the gray, the orange line, the reoperation for sublay. So you see the difference is still there between both groups. This picture you have seen already. Now I want to talk about the DynaMesh IPOM mesh, which is made by polyvinylidene fluoride. Dr. Schuster already told you about the characteristics of this mesh. And I think this is, for me as a clinician, the most important picture when you see for this cross-sectional view the difference in the granuloma thickness, because we surgeons always fear with the intraperitoneal mesh a big granuloma and adhesions. So I think this is a very, very important picture for the discussion of this issue. Pictures of the mesh have you seen already, and I will show you some intra-abdominal pictures when we started with this operation. Here you see a normal incisional hernia covered with the IPOM mesh, and you see this picture is at least 10 years old. We used at that time still the metal tags. We are not using them anymore, and you see that you have big meshes and you can cover all the intra-abdominal space, even down to the pubis. And then you see here the nice characteristics of this mesh, where you can see through the mesh. You see the tissue behind the mesh, which is quite important, and you can make your fixations here. And you see we use this mesh quite often also for the parastomal hernia repair here in the sandwich technique, published by Professor Berger. And then now here you see another example, 54-year-old woman with a very big parastomal hernia 1 year after abdominal perineal rectum extirpation. And we covered after retraction of the sac and fixation of the sac here, we covered the hernia also here in the sandwich technique. Now you see the tags are now resorbable, but it's the same material. And then we also use quite often this mesh, the visible mesh, for the hiatral repair for big hiatral hernias, with the big advantage that you have the possibility after the operation to have the visible mesh, and you can see if there are problems when you have dysphagy and things like that. You make an MRI and you can see whether you have a mesh problem. So talking about the DynaMesh IPOM, we have the latest data for this mesh here, published in Annals of Surgery last year. Also data from the Danish registry. And they showed that the DynaMesh mesh has in the group for primary ventral hernia the lowest recurrence rate in the 10 years follow-up. That's a very long time, and I think that's very important data. And also for the incisional hernia, the DynaMesh IPOM mesh showed the lowest recurrence rate after 10 years. So in this long follow-up period, this result is very important. So we can conclude regarding incisional and ventral hernia repair that, for example, the findings of this propensity score matched analysis I showed to you and all the data from the registry from daily surgical routine are in complete concordance with the existing meta-analysis. I showed you that the intraoperative complications like bleeding and bowel complications are the so-called Achilles heel of the laparoscopic repair. But the major disadvantage of all the open extraperitoneal sublay techniques is the very highly significant increased rate of surgical site occurrences, including infections, seroma, and so on, which quite often require reoperations. And of course, there are now the new kids on the block like Milos and so on. But for these procedures which are still open, we don't have long-term data at the moment. So overall, I can state that the laparoscopic IPOM technique shows clear superiority over the open supply report. But given that the surgical expertise is evident, I talked about the longer learning curve. And DynaMesh IPOM mesh shows ideal characteristics in handling and implantation for incisional and ventral hernia repair and the lowest rate of reoperations for recurrence. Thank you so much.
Thank you, Dr. Simon, for this very interesting presentation. Yeah, I think once again it shows us that there is a place for the laparoscopic IPOM, even though maybe sometimes on the congresses it has gotten a bit quiet around this topic. But yeah, once again the data really speaks for itself. I don't see any questions right now in the chat or any raised hands. If there are any questions, please feel free to drop them in the chat or raise your hand at any point. I think in the meantime now, we maybe move to Dr. Luedtke and the next presentation on the TAP, the TAPP. Our Dr. Schuster has raised his hand.
Just a brief additional comment, if I may. Brilliant presentation, Dr. Simon, thank you. I just wanted to add an information which highlights the reliability of the data of the Danish hernia register. So there are many registers available all over the world. And for many of them, the case is if the patient changes the doctor, then and for recurrent treatment, for any other treatment, it will be created a new case. While in the Danish hernia register, there's a patient individual identification number, which guarantees really 100% follow-up, so no dropout rate. Even if the patient changes the doctor can identify the patient in the register. So this really underlines the reliability of these data, which is an important additional aspect of these data.
Yes, I think I can confirm that, and we have the problem in the German database that we don't have this individual identification.
Okay, yes, thank you very much indeed. Okay, then if there's no questions from the audience at this point, maybe at the end of the session we open the floor again. Then now we come to Dr. Clinton Luedtke, who is going to present the TAP technique and his presentation 3D mesh augmentation in TAP inguinal hernia repair. Dr. Luedtke, please share your screen and activate your microphone.
Can you hear me?
Yes, now we can hear you.
Okay, then here, where is my lecture? Okay, do you see my presentation now?
Yes, and now also in full screen. Perfect.
Okay, so my lecture will be about the TAPP technique, laparoscopic inguinal hernia repair with a 3D mesh augmentation. So first of all, inguinal hernia repair. Where are we worldwide and in Germany? It's annual repair of over 20 million cases worldwide. And in Germany, with a population of 83 million, it's still 275 cases a year. So inguinal hernia repair is high volume surgery and general surgery wards, and actually bread and butter technique. But how to treat inguinal hernia repair, inguinal hernias? Recommendations are with the hernia search group, and they make it very clear. It's recommended to use mesh-based repair. And if you talk about mesh-based repair, what technique is recommended? And here the guidelines are also very clear. It's laparoendoscopic wherever you look. It's male patients, primary unilateral inguinal hernia. Laparoendoscopic techniques are recommended, since this technique may reduce chronic pain when you go the open way, ventral procedure, you're likely to cut nerves rather than if you go from the abdominal side, posterior side. And laparoendoscopic is also recommended in primary bilateral inguinal hernias, since you use the same door to get to your hernia, no matter if it's right or left side, you be there. And women, it's also recommended laparoendoscopic, since in women the rate of femoral hernia is bigger, and when you go from the ventral side, you're likely to miss those hernias. And of course, if you had a previous ventral repair and it failed and you have a recurrent, and you go the other untouched region, the posterior region, to get it fixed. So guidelines are clear in favor of a laparoendoscopic technique. How are our patients treated now? And here, like Dr. Simon was talking about before, there is the German hernia registry, HerniaMed. And when you look at those data, first, HerniaMed is a registry founded in 2009, so it's 13 years now. And every surgeon interested in hernia repair can contribute to this registry, with a growing number of clinics and patients in Germany, Austria, and the German-speaking Switzerland. It's a German-based or hernia registry in German language. So it's those three countries in particular. And meanwhile, we have over 1 million data of patients treated. So it's a broad registry, ever-growing registry. And it's also a quality assurance program with a follow-up 1, 5, and 10 years after surgery. So and if you have a look at all hernias treated in HerniaMed, it's 70% inguinal hernia repair. And if you split it further, it's 38% TAPP and 25% TEP. So laparoendoscopic repair makes up 63% of all inguinal hernia repair. So that means that in the HerniaMed registry, 44% of all patients treated with a hernia need a laparoendoscopic suitable mesh. And here you see our clinic. We do 81% laparoendoscopic, meaning the TAPP repair. It's a little more than in HerniaMed, but still, as a hernia surgeon, you cannot stick just to one technique. So you always need to be able to operate a open mesh procedure, since there will be always patients with previous operations in the lower abdomen, prostate cancer patients. So there's scarred tissue, and you would do more harm with a laparoendoscopic repair than with a open procedure. And there are patients who just don't want a mesh for whatever reason, and then you need a suture repair also. So now, what is our mission in inguinal hernia repair? What do we want? Of course, we want a good outcome. We want a low recurrence rate and few chronic pain. And what contributes to that mission, what influences our goal? It's the patient itself, it's the surgeon, and it's the material, it's the mesh. And starting with the patient, what is not so good is smoking, obesity, collagen disease, previous lower abdominal surgery, previous hernia surgery, recurrent hernia, and any form of anticoagulation leads to a not so or good outcome. But actually, it doesn't matter, because it's very hard or almost impossible to improve this. This is my experience. There's the patient has a hernia, the patient has pain, suffering from the hernia, and then you just take him like he comes. So you can't do much to improve. But you as a surgeon, you can do something to get a good outcome. So you need skills, experience, and you need a good knowledge of the anatomy of the posterior inguinal wall. And what helps you here is in recent years, Dr. Edward Felix came up with the critical view of the myopectineal orifice and a checklist with the 10 golden rules, or the 10 commandments of laparoendoscopic inguinal hernia repair. So critical view of myopectineal orifice, the weak spot in the groin where the direct, indirect, and femoral hernias are, helps you to see, did you do a good preparation before you place the mesh. So let me go just real quick through the 10 golden rules. Rule 1, when you begin surgery, start the peritoneal flap 4 centimeters above the deep inguinal ring. So you have, in the end, a good landing zone. Rule number 2, dissection should follow the peritoneal plane. So this is very crucial, that you keep the fatty tissue to the inguinal wall, and you don't go too far to the wall. And you need to protect the nerves and vessels, and this you do best when you stick to the peritoneal plane. Rule number 3, medial extent of dissection. It's very important that you go very far to the medial part. The pubic symphysis should be visualized in every case, and if you have a medial hernia, a direct hernia, go even a couple of centimeters farther, and you need to reach at least 2 centimeters below the pubic bone. You should suture the transversalis fascia to reduce the risk of seroma in big direct hernia. Rule 4, external iliac vein should be visible. Why is that? Because here you spot femoral hernia, and you don't want to miss femoral hernia. You have to discriminate lymph nodes from preperitoneal fat. Lymph nodes is no hernia, so you can leave this alone. Rule number 5, extent of inferior peritoneum dissection, the choric peritalization. It is also crucial that the vas deferens, when it crosses the external iliac vein, needs to be dissected. The iliopsoas muscle needs to be dissected under fatty tissue, so stay to your peritoneum plane. And the indirect sac dissection, this is the most challenging part of inguinal hernia repair laparoscopically, since you have to separate the sac from the cord structures. And in women, the round ligament can be transected, and in most cases you would transect it because it sticks very much to the peritoneum. You get holes in the peritoneum, so you can transect it, but you should do so 1 centimeter proximal to the deep inguinal ring to protect the nerves, the genital branch of the femorogenital nerve. Rule 6, management of indirect sac. So when you have a real big indirect hernia sac, a large one, chronic fibrotic one, transection of the distal part is better than to remove the sac in total, whatever it costs, because it's only feasible though after you identify all elements of the spermatic cord. So this must be first, but then you can transect the tip of the sac, because pseudo-hydrocele is easier to manage than hematoma, cord injury, or ischemic orchitis. Rule 7, check inguinal canal for choroid lipoma. Choroid lipomas come from the lateral to the choroid elements, and choroid lipoma are a major cause of recurrence. You should dissect and reduce a lipoma. It's not necessary to remove it in all cases. You can just reduce and dissect it to dorsal and then put it on top of your mesh. So, and if you've done all that, then you have to stop and have the critical view of the myopectoneal orifice. And you look for the inverted Y on the 5 triangles. I'll show a slice later on. And you check if you recognize all anatomical elements in the groin. You check for hemostasis, and you check if your landing zone is ready and big enough for mesh repair. So the white strips are the inverted Y. It's on top, it's the inferior epigastric vessels. Then at the bottom part, you have to the medial, it's a picture of the right groin, the vas deferens, and lateral, the spermatic vessels. And then in the middle, you have the triangle of doom, where the vessels are, lateral triangle of pain, where you can hit the nerves, ilioinguinal nerve, the nervus genital femoralis, and the cutaneous femoral nerve. Then you have the 3 spots of the potential hernia size: femoral triangle, direct triangle, and indirect triangle. So now we come to the mesh. Golden rule 8, mesh size. It should be at least 10 times 15 centimeter. and cover all the myopectineal orifice. Overlap is needed in all directions, 3 to 4 centimeters, and be sure to reach the pubic symphysis and go 2 centimeters below the pubis. So it's between pubic bone and the bladder. The edge of the peritoneum must be below the mesh to prevent folding. This is essential. Rule number 9, mesh fixation is not necessary, and especially with this anatomical mesh, with the 3D mesh you will see later on, you don't need fixation. Fixation also cannot fix inadequate dissection. So dissection is essential, and if you don't dissect well, you can fixate as you want, but you won't have a good outcome. Injury and pain through penetrating fixation can occur, and plus it's an extra cost if you use glue or tackers. Rule 10, last rule, deflate under direct visualization. So it means if you close the peritoneal flap, you have to be sure that the mesh doesn't lift up. If it does, then you need a wider dissection. So here, the influence factor of the mesh. Dr. Schuster explained it in detail. I just want to make it short here. But what I feel as a surgeon, it's logical that in the end, after the granuloma as a foreign body takes place, you want to have a high effective porosity, because every surgeon has said a mesh that is like a bone, because there are no pores after the granuloma has taken over, and this is very annoying, and patients suffer from this. So high effective porosity is very important. Of course, Pvdf has a high aging resistance and low degradation, minor foreign body reactions. So these are all things that make us happy with this sort of mesh. Here you see the form of the anatomical shape form for the groin, and this will help placing the mesh. So now a video about 7 minutes long of a male patient, 68 years old, with a bilateral inguinal hernia. At the right side, he has a direct hernia, big hernia reaching the scrotum, but it doesn't hurt. Left side is a rather small hernia, but it hurts. He has a previous open appendectomy and anticoagulation with aspirin. So I'm starting the video now. Now we look into the abdominal cavity, and we see to the right adhesions from the previous open appendectomy.
Dr.
Large direct hernia.
Pause the video. We have a question.
Oh yeah, okay.
Asim Shabir, you may activate your microphone.
Hello?
Mr. Shabir, can you activate your microphone? Okay, maybe continue. Maybe it was a raised hand by mistake.
Okay, so yeah, we can talk about this after the video, maybe. Now we look into the abdominal cavity and we see to the right adhesions from the previous open appendectomy. We see a large direct hernia and there is a small intestine fixed to the hernia orifice. At the left side, this is where the hernia is hurting. We see nothing but attached sigmoid. Now we increase the speed of the video a little and start with adhesiolysis to get access to the right groin. Golden rule 1 and 2, start peritoneal flap 4 cm above deep ring. Follow the peritoneal plane and keep fatty tissue to the wall, protecting nerves and vessels. You can do blunt dissection into the retius space, the space between bladder and pubic bone. Here you see the pubic bone, and in direct hernias it's also most times easily possible to do blunt dissection. Here we free last preperitoneal adhesions. Here's the peritoneal flap with the direct hernia sac and the adhesive intestine. When you dissect the medial zone, make sure to stay on the peritoneal plane to avoid injury to the cord structures. Direct hernia sac to the left and intestine to the right. Here's the vas deferens. Following the vas over the external iliac vein leads you to a femoral hernia, if there is any. In large direct hernias, I suture the transversalis fascia to avoid seroma, since a seroma can lead to a recurrence. Now we move forward to the left side and look for the arcing hernia here. Here it is. It's a direct hernia also, not so big, but aching. Dissecting the medial zone now. Stay close to the peritoneum. Here's the vas deferens. The first mesh is already placed in the left groin, It's a 10 times 15 centimeters envelop 3D mesh. We do have a broad landing zone. The bottom of the mesh is way down and the mesh covers the entire myopectineal orifice. Here's the center of the mesh, marked with a green thread and placed over the direct hernia. Now the mesh for the right groin. This is to demonstrate how to get the mesh in the body. You fold it 3 times and then 1 more time, grasp it, and it slides easily through the trocar. The memory effect of the anatomic mesh is helping us to unfold it, and it also helps us to move it to the right position. You can see the mesh seems to stick to the inguinal wall by itself. So you can spare the money for fixation devices, and the patients don't suffer harm from fixation. The myopectineal orifice is completely covered by the meshes. The meshes overlap in the middle over the pubic symphysis, and they reach deep in the retius space between bladder and pubic bone. Again, it is important to have the edge of the peritoneum below the mesh to prevent folding. We close the peritoneum with a resolvable barb suture. If the mesh is lifting when closing the peritoneal flap, more dissection is needed. The repair is completed. So this is a picture of the left groin after mesh implantation. And you see the inverted Y. You see triangle of doom, pain, and the spots of the weak spots of femoral, direct, and indirect hernia. And here you see in the middle the 2 meshes overlapping, and yeah, this is how it should look. So I say thank you very much for your attention, and yeah, it was a pleasure to be here.
Yeah, thank you very much, Dr. Luedtke, for this interesting presentation as well, and this very extensive instruction on how to ensure correct placement for the ideal outcome for our patients. I see the hand has been lowered again, so I assume it wasn't a question after all. Are there any more questions to any of the presentations we have seen so far from the audience, or we have seen today? As there is a raised hand again from Dr. Schuster.
Yeah, one question to both of the clinicians, Dr. Luedtke and Dr. Simon. Considering product-specific properties, product singularities, would you recommend to attend a workshop before using the devices for the first time, or would you say an experienced surgeon can use all of the products without any specific attention to the product-specific properties? This is to both, and then a second question to Dr. Simon. Maybe a stupid question, but I'm brave enough to ask it anyway. If it comes to criticism of the IPOM technique, it's all about the risk of an ileus. And I'm not talking about the late complication, the late ileus. I'm talking about the ileus in the early postoperative phase. Let's say first 5, 6, 7 days, which is often mixed up with the paralytic ileus. Are there, in your experience and according to your algorithm, are there any tips and tricks how to overcome the paralytic ileus? Any balanced diet or medication or anything like this?
Yeah, Dr. Schuster, thank you for the questions. There are no stupid questions at all. I can overlook now, I think, about 800 lab IPOMs, and I think the postoperative ileus for this operation is not a daily problem. It's very seldom, but of course it can occur. And in my opinion and my experience, our patients always get some ingredients like magnesium, like, for example, also the patients get when they were operated for colorectal cancer and they have to move out the bed. We have this early mobilization, and then the other thing is just to wait. So there is, in my opinion, if you don't have a bigger problem like postoperative complication, it's just to wait. Yeah. And regarding your first question, I think if the surgeon is experienced, he probably won't need really a workshop, but it's important to address some points in the handling of the mesh. So one thing is, for example, a question of fixation. How can the mesh be fixated with a suture, with tackers, with glue, whatever? So I think these questions have to be answered and discussed, and then of course some special, you have different products when you use the mesh for the artery repair, or if you use the endolab mesh or whatever. So you have specific things to discuss regarding this product, but I think you can address those questions easily while discussing before you use it. So I don't think that a workshop is really necessary.
Brilliant. Thank you very much.
Yeah, that's what I figure also, that the products are very easy to handle and self-explaining. So you don't need a workshop. It might help that when you use them the first time, that a person from DynaMesh is with me in the theater and gives us some tips. So that is good. But yeah, they are basically self-explaining. And since we switched to the endolab meshes, from that point on, we didn't need glue anymore. Before this, we always glued in every patient because we didn't have a very good feeling that this will hold. It's important. It holds the first couple of days until the mesh is fixed. But with the DynaMesh and endolab meshes, like I said, you have the feeling that it sort of sticks by itself to the wall. So in the anatomical form of this mesh fits perfectly. So you need a good and broad dissection. And if you have a good landing zone, the mesh basically does it by itself. Easy to handle, easy to get it to the right position, and it sticks there and stays there.
Perfect. Thank you.
Thank you. Dr. Simon, you raised your hand, and also we have a question for you. How do you want to answer a question first, or do you want to comment?
Yeah, I can answer both things. I just want to point out that regarding the postoperative ileus, in my experience, in the beginning, when we started with lab IPOM, we did a lot of adhesiolysis. So we forced us to get it to the end, the laparoscopic approach. And I think it's very important that you have a kind of rule how long you proceed with the adhesiolysis. We had some severe complications in the beginning due to this adhesiolysis, and so I have now the rule for myself. I make it half an hour and then I stop it and I convert to the open approach, because concerning postoperative ileus, concerning other problems, complications, the adhesiolysis is very important to be careful with that. Yeah, that's one thing. And the other thing is also, I think, one reason why perhaps the results are like they are is that we have in the guidelines, I didn't talk about that, but we have this margin that you should not operate on very big hernias, like more than 10 centimeters of width with this technique. Then you won't get good results. So I think you have to take into account those two things, not to operate on too big hernias and don't go too long with the adhesiolysis. And the questions from the audience, thank you very much for your question. For me, nowadays, I only do IPOM plus. So if I can't close the defect, I'm not doing IPOM. I combine IPOM then with the endoscopic anterior component separation. But I think it's very important to adapt the rectus sheet and to close the defect before you apply the mesh. Yeah, so I hope I can answer this question.
Yes, thank you. Indeed, Dr. Eugenio, if you have any follow-up, please feel free to write or even raise your hand and we can activate your mic as well if you want to. But if there are no follow-up questions, then I think we come to an end for today's session. Pretty on time as well, so everyone in Singapore can enjoy their weekend ahead. We still have a couple of hours to go, but also not too much longer. Yeah, once again, thank you very much, Dr. Schuster, Dr. Luedtke, Dr. Simon, for your presentations, for your time. Thank you very much to the audience for attending today's sessions. I'm sure our local partner MedQuest and our local team will be in touch with you shortly. I personally, as the responsible distributor manager for Singapore, hope to be in touch with you as well, personally, at some point in the not too far future again, when travel eases up again a bit. And yeah, once again, thank you very much, everyone, in the name of DynaMesh, from all of us. We wish you all a nice weekend. Stay safe, stay healthy, and we hope to see each other again personally very soon. Thank you. Goodbye.
Thank you. Bye-bye.
Bye.